Okay. Well, good morning, everyone. As Linda said, I'm Ruth, and I'm a transfusion practitioner for the Rosie Hospital. My part of my role is to act as a liaison person between the laboratory and the clinical area, with regards to making sure that we have blood available for some of our more challenging patients. Okay, so say as Tamsin was saying earlier, it's really important to be prepared, particularly when you've got, should we say, challenging patients with antibodies, because again, as Kath said in her talk, um, sometimes it can take quite a long time to get blood ready for a patient, which if they're having a major hemorrhage is not really much good. So we may well need to have blood available beforehand. So I'm going to present 3 cases that we have had at our hospital. We have quite a good system that every Tuesday morning we have a meeting with the laboratory and our transfusion consultant and myself, and the laboratory highlight any challenging cases with antibodies, and we keep an eye on them. We monitor the level of the antibodies, and we liaise with the feto-maternal medicine team so that we can be prepared, so that bloods can be available in good time should it be needed. So our first case, she came for her 4th pregnancy and her blood group was OD positive. And her first pregnancy, there was a stillbirth. A second pregnancy was an uncomplicated pregnancy with a minimal blood loss. However, by her 3rd pregnancy, the booking bloods had shown that she had got an anti-little c. Now, with regards to antibodies, there's what we call the big 3. There is anti-D, anti-little c, and big K, commonly known as, or used to be known as KEL. Now, anti-D and anti-C cause hemolytic disease of the fetus and newborn, and anti-K, big K, acts slightly differently, but can cause severe fetal anemia. So we've got an anti-little c here. So with this baby, her level had risen to 23.1 international units per mil by the end of the pregnancy, and her baby required phototherapy. So by the her partner was tested, and he was found to be homozygous for the little c antigen, which therefore meant that all children from this partnership would be little c positive. So when she arrived for her 4th pregnancy, we were well versed, we knew what to expect, and we monitored her carefully. So when a mum has one of the big 3 antibodies, there's a testing protocol. They're tested every 4 weeks up until 28 weeks gestation, and then every 2 weeks thereafter. So booking blood was, the level was 5.3, and we did some fetal genotyping, and that did indeed confirm that the baby was little c positive. And the level continued to rise until 32 weeks, when she was 18.8 international units. And at 34 weeks, a routine Doppler scan showed that there was a high risk that the baby was in fact anemic. So they decided that they were going to deliver her early. So she was admitted for steroid injections and prepared for induction of labour. Now, when a lady has anti-little c,
it's disappearing.
When there is a baby that a mum that has antibodies, there is a double trouble, if you like. The baby's at risk of severe hemolytic disease of the fetus and newborn, may require a top up and or exchange transfusion, so we need to be prepared for that. The mum, she was at increased risk of bleeding due to the fact it was an induction of labour, multiple births, her age, her obstetric history. And because of the antibodies, she would require a full serological cross-match because of the antibody. But there is one further problem. And as Tamsin quite rightly said, that there are emergency OD negative units in every delivery unit fridge. That unfortunately, in this instance, the emergency O negative units are not suitable for this particular mum because they are little c positive. So they would cause a transfusion reaction for the mum. So they are actually not suitable. So we also had to take that into consideration. So what did we do? So we put a plan in place. So for mum, the laboratory provided 4 units cross-matched, and these were sent over to delivery before the induction of labour had even started. There was an alert put in place on her notes that the emergency OD negative units were not to be used unless it was literally life-saving. When the induction of labour commenced, the laboratory cross-matched a further 4 units and sent those over to delivery unit. The laboratory were made aware we have a blood track system, so we can monitor when units are scanned out. So they were made aware to monitor the use of the blood, and so if any blood was taken, they would know how much, what was available, and if it started to look a little bit on the low side, then they would cross-match some more and send it over in good time. For baby, there was a paediatric full set of a PediPack cross-matched against the mum's plasma, labelled as compatible for the baby of the lady, and sent over to delivery unit just in case the baby required an urgent transfusion on delivery. So how did it? Oh, and the National Blood Service put a couple of units on hold should the baby then require an exchange transfusion. But as it turned out, the baby boy was delivered by caesarean section with a reasonable hemoglobin and in not too bad condition. He did receive double phototherapy, reduced to single on day 2. On day 2, the treatment was stopped and he was successfully discharged home on day 17. And there was actually, after all that, no blood required by mother or baby. So everything was in place, but fortunately it was not needed. Okay, so moving on, we had very recently actually a lady presented for her 3rd pregnancy at 9 weeks gestation and was found to have a positive antibody screen, and the laboratory identified this as anti-D. Unfortunately, we were unable to send it off for quantification as there was insufficient sample, so a repeat was immediately requested. At 13 weeks, the cell-free fetal DNA test predicted the baby to be D positive, So it was vital that we confirmed whether this was passive or immune. We're at this point, we're sort of 99% certain that it probably is immune, but we do need to double check the history, because it may be possible that she'd had a miscarriage or a termination, and there was still a slight amount of anti-D in her system. Her repeat sample at 14 weeks showed that the level was less than 0.1 international units per mil. So again, it's technically could be either, but it's more, we're sort of virtually 100% sure, but we do need to double check, because we don't want to miss a dose of anti-D if it isn't immune. So we had a little dig, tried to have a little dig into her history. We had no history on file anywhere and no evidence of any anti-D administration. And we didn't really have any information, as the lady concerned was a refugee from the Ukraine. So she apparently had 2 children, 12 and 9 years earlier, which were both uncomplicated spontaneous vaginal deliveries. So we've then requested a new sample as per protocol for 4 weeks' time. Fortunately, in this period, there were no sensitizing events, so we didn't have to do any more regarding that. So 18 weeks, we had our answer, our definitive proof that the level was now 14.4 international units, and she was already at 18 weeks at moderate risk for hemolytic disease of the fetus and newborn, and that had risen to 44 by 22 weeks. There was evidence of high drops seen on her scan, so she was sent to King's College Hospital London for an intrauterine transfusion. And this is quite a rare occurrence, particularly this early in pregnancy. We had a report back from King's College to say that at the time of the intrauterine transfusion, the baby's hemoglobin was actually 16 grams per litre. And quite honestly, I've never heard of a hemoglobin that's that low. So basically, if she hadn't had that intrauterine transfusion there and then, I think that the baby would have unfortunately demised. This transfusion raised the hemoglobin to 69, not brilliant, but a lot better. The next week, she had another intrauterine transfusion, and the hemoglobin reached a much more respectable 125 grams per litre. Mum's anti-D level continued to rise. Now, because of the very low hemoglobin, the baby had obviously suffered from severe hypoxia, so they were sent for a brain scan, and at that time the brain looked, fortunately, structurally normal. But Mum's antibody level still continued to rise, and by 27 weeks, again, another intrauterine transfusion was indicated, as the hemoglobin had dropped from 125 to 65 grams per litre. And then again at 31 weeks, another intrauterine transfusion was given. Following that, the next 4 scans done weekly all showed that the baby was not anemic. So unsurprisingly, the delivery was planned early for elective caesarean at 35 plus 5 weeks. And to add to matters, Mum was also a major placenta previa. So what we put in place was there was 4 units cross-matched ready for Mum. We had 6 irradiated PD packs available, cross-matched for baby. These had to be irradiated because when a baby has had an intrauterine transfusion, they do require irradiated blood, and we had 2 exchange units held at Cambridge National Blood Service. We were fairly convinced that we would actually need them, so they were on standby for us to get immediately should baby need it. So for mum, delivery was fine. She didn't actually require anything at all. As far as baby was concerned, it was documented that the baby, a little boy, was born flat, floppy and pale, had respiratory distress with a hemoglobin of 87 grams, with the bilirubin just above the exchange transfusion line. However, at this point, they decided not to do an exchange transfusion. The baby was put in a billy blanket, double phototherapy, and IVIG was given, along with a top-up transfusion. Phototherapy stopped on day 2, and then a further top-up transfusion was required on day 4, and on day 14, the baby was discharged. Now, you might think that's the end of the story. However, at this point, the hemolysis was not resolved. So 4 weeks later, at the follow-up clinic, baby's hemoglobin was 70 grams per litre, and he was booked to come back for a top-up transfusion. Now, why this was still going on was because some of mum's antibodies were still in the baby's circulation and was still destroying the baby's red blood cells. So the hemolytic disease was still carrying on. The mum's antibodies hadn't quite got out of the baby's system. So he was booked to come back in for a top-up transfusion, but before that could happen, he came into ED, hemoglobin 55 grams per litre, and the top-up transfusion was given earlier than it was expected. Now, at this point, we still can't actually group the baby. On delivery, he was grouped as O negative, but that obviously was not his real blood group. That was because he had had 4 intrauterine transfusions of O negative blood, and his antibody screen was still positive due to the mum's antibodies still circulating in his system. Even at 8 weeks, it was still happening, and his hemoglobin had again dropped to 55 grams per litre. So a further top-up was given. Still some of mum's antibodies circulating round. After that, fortunately, the antibodies did start to clear. The hemoglobin began to rise, and by 4 months of age, the hemolytic disease seemed to have resolved itself. However, this is quite a new case. Literally happened sort of at the end of last summer. So just to check for any neurological impairment due to the hypoxia, the baby will require a brain scan between 6 and 12 months. So we don't quite yet know the full extent whether there was any lasting damage to the baby. So at the minute, this one is unresolved. Okay, so the final case study is a very rare antibody. It was one that I'd never come across, and as you can probably see, I've been in transfusion quite a while, and I've never come across this before. So a lady appeared for her booking bloods at 7 weeks, and she was AD negative with a positive antibody screen. So the first thought is anti-D, but it wasn't. After much testing in our laboratory and a confirmatory sample sent to the National Blood Service, the antibody was determined to be an anti-little k. and that is different from big K or Kel, and the titer was 2. So this lady's background was she had a delivery at a different hospital with a ppH of 1.5 litres and had 1 unit of red cells transfused. And these were A negative, big K negative, as would be per protocol. So she hadn't received any blood that she shouldn't have done. There was no errors involved. She'd received exactly what she should have done. Okay, so big K and little k are co-dominant alleles of the Kel blood group system. 91% of the population are big K negative, little k, and that is why women of childbearing potential are routinely given big K negative red cells, because bearing in mind that big K can cause fetal anemia, we don't want the ladies to make anti-big K. So she was quite rightly given K negative blood, which unfortunately for her is little k positive. Now, again, 8.8% of the population are big K, little k, so the Kel negative, big K negative blood is suitable for them as well. She was one of the 0.2% who are big K plus, therefore little k negative. And judging on her blood group, A negative, the likelihood was that 1 in 4,000 units would be compatible with her. So bearing in mind the National Blood Service's stock levels, there would be around about 6 units that were available in the entire country. So we have mum, we have a lack of available compatibility of blood should she require it, and the baby has the potential of fetal anemia. So obviously she was referred to the fetal maternal unit. We had dad's sample sent to NHSBT, and he was found to be little k. So there was a 100% chance that the baby would be little k positive. So our testing protocol for little k is the same as big K, every 4 weeks till 28 weeks and every 2 weeks thereafter. So the good news was that the titers remained low and all the Dopplers were normal. But the bad news for us was that at 25 weeks, mum was found to have a full placenta previa, so she was at a high risk of bleeding. So again, we put plans in place. The baby, say Dopplers were still fine. Delivery was planned for cesarean section at 38 weeks. So the laboratory started to source blood and ordered it to be put on standby, ready for delivery. At this time, there were 4 units available in the country. 2 were reasonably close and 2 slightly further afield. Mum's haemoglobin at 34 weeks was 118 grams per litre. So she had 2 doses of IV iron planned for 35 and 36 weeks. As Tamsin said earlier, there wasn't time to put her on tablets. She had to have IV, so this was booked in. At 35 weeks, she had her first dose, so it was all going very well so far. However, 36 plus 1 at 3:30 a.m., the patient presented with PV bleeding. This did settle, but at this point, I think they knew with her blood group, the difficulty getting blood, that now was the time to deliver baby. They couldn't risk having something happen out of hours without any blood available, because As I said earlier, the emergency O negative units are big K negative, little k positive, so they would not be suitable to give to mum. The blood was sourced in by the laboratory and cross-matched. I took the 4 units of blood into theatre in a cold box just to make sure that the emergency O neg units were not taken if things did kick off and people forgot and just rushed to the fridge. Cell salvage was ready to go as well. So after all this, she had a baby girl who was safely delivered. Mum had an estimated blood loss of 500 mils. So actually, after all that, no blood was actually required. Baby did have a positive direct antiglobulin test. Now that could have been due to mum's anti-little k, or it could have been due to passive anti-D because, as I said earlier, mum was in fact D negative. The baby's bilirubin level did rise after birth and phototherapy was required, but fortunately all was well in the end and baby was discharged on day 7. So I hope you found them interesting, and I hope it's highlighted the need for communications so that we are prepared for when things do go wrong, so that we can give our mums the best care. So thank you for listening, and I'm happy to take any questions on the chat or Q&A session.